The PTCL had many challenges. Probably the one that is the most significant at the moment relates to the heterogeneity or diversity of the disease. We now have two different classification schemes, the ICC and the WHO, which recognize, let's call it 35 different types of T-cell lymphoma. And as a group, they're awfully rare diseases, maybe in the United States, 10,000 cases per year. And even with the most common subtypes, maybe a couple of thousand patients per year. So this makes it very hard because those 35 different subtypes are all biologically very different. And as we're seeing in lots of new data sets with new drugs, some subtypes respond amazingly well to one class of drugs, while other subtypes don't. And how these relative proportions of patients with these different subtypes can then influence the outcome of these trials becomes pretty significant. And it has an impact on how we develop these drugs for those diseases. So I think the notion that there's incredible heterogeneity, that heterogeneity is reflected in differences in biologic behavior, differences in genetics, and ultimately differences in vulnerability to different drugs, makes it very, very difficult to develop a singular, unifying platform of care for all types of T-cell lymphoma. And it presents a challenge as to how we go about getting drugs approved for the disease.
PTCL represents a category of highly aggressive and heterogeneous non-Hodgkin lymphomas characterized by a myriad of subtypes, each regarded as a distinct disease entity. These subtypes exhibit significant differences in clinical manifestations, pathogenesis, molecular genetic profiles, and prognosis, posing considerable challenges for therapeutic interventions. In general, the majority of T-cell lymphomas lack standardized treatment protocols and have poor survival outcomes, except for early stage NKT cell lymphoma and ALK-positive anaplastic large cell lymphoma. The 5-year overall survival rates for other subtypes are generally low, often not exceeding 30%. Notably, there are notable geographical variations in the incidence of peripheral T-cell lymphoma subtypes. In China, NKT cell lymphoma, peripheral T-cell lymphoma not otherwise specified, and angioimmunoblastic T-cell lymphoma are the primary subtypes, whereas in European and American countries, ALCL and cutaneous T-cell lymphoma are more prevalent. In response to the severe challenges posed by PTCL, the medical community in China has conducted extensive research on various types of peripheral T-cell lymphomas. Professor Zhang Huilai team at the Lymphoma Department of Tianjin Medical University Affiliated Cancer Hospital has achieved certain results using azacitidine combined with ketamide, a dual epigenetic therapy for the treatment of relapsed or refractory PTCL. Based on this, they initiated a prospective, multi-center, randomized, controlled phase 3 clinical study comparing dual epigenetic therapy combined with CHOP versus CHOP alone in the treatment of naive follicular helper T-cell phenotype peripheral T-cell lymphoma. Professor Zhao Weili team at Ruijin Hospital has made significant achievements in the field of NKT cell lymphoma. They conducted subtype exploration and identified 3 subtypes, TSIM, MB, and HEA, which differ in their sensitivity to drugs. Meanwhile, Professors Huang Huiqiang and Cai Qingqing at Sun Yat-sen University Cancer Center have also made crucial breakthroughs in clinical research on NKT cell lymphoma. Their proposed immune epigenetic therapy has demonstrated remarkable efficacy for patients with relapsed or refractory NKT cell lymphoma and further explored first-line and combination treatment strategies. In summary, China has achieved in-depth research results in the types of peripheral T-cell lymphomas with high incidence rates and holds promise for providing more effective treatment concepts and strategies for patients worldwide.
Well, the current standards of care typically involve some form of chemotherapy. And the type of chemotherapy folks pick is usually modeled after how they treat B-cell lymphoma, a radically different disease. And so when it comes to combination chemotherapy, we really don't have that much great data to say what combination chemotherapy works best in the relapsed or refractory setting. I think as a general statement, that's true. Most chemotherapy in the relapsed or refractory setting is not effective. And I believe if you look at the data, and most of it is retrospective, we don't have prospective randomized studies, it would suggest that new drugs, using them earlier, will work better. And there's data that we've published with pralotrexate, there's lots of data with histone deacetylase inhibitors and other drugs. And so it's my very strong opinion that we wait too long to start these new drugs. And here in China, you're extraordinarily fortunate. You have a lot of new drugs that we don't have in the United States. And you've got 2 new ones potentially pending, including the PI3K inhibitor and the EZH2 inhibitor. And you already have other approved agents. And I would suggest, because I do it in my own practice, that we use those novel drugs as early as possible. Because what the data suggest is they can have a big impact. And in the case of pralotrexate, using the drug earlier has been shown to have impacts on overall survival. And I think that paradigm is going to hold true as we begin to develop these other drugs. And secondarily, I think clinical trials. I think we need to start studying these drugs in combination, new drugs. We need to prioritize studying those new drugs in combination with each other over chemotherapy and really try to get patients into those clinical trials as efficiently and rapidly as possible so we can better understand how to develop what the next relapsed refractory setting therapies might be.
In the treatment of relapsed or refractory peripheral T-cell lymphoma, the therapeutic considerations for Chinese patients are particularly complex. Firstly, a detailed analysis of the patient's specific pathological type is required, as different pathological types exhibit unique pathogenesis and molecular genetic characteristics, which provide critical evidence for doctors to develop more targeted therapeutic strategies. Furthermore, when devising treatment plans for Chinese patients, it is necessary to comprehensively consider their physical constitution, functional status, economic capacity, and personal treatment preferences. It is noteworthy that patients with relapsed or refractory disease have often undergone multiple treatment regimens and drug therapies. Therefore, when formulating subsequent treatment plans, it is crucial to thoroughly review their past treatment regimens, assess treatment efficacy, and consider side effects. Hence, when customizing treatment plans for individual patients, multiple factors must be comprehensively weighed to strive for an optimal balance between efficacy and toxicity. As Professor Owen has pointed out, there are numerous clinical trial projects currently ongoing in China, providing diverse treatment options for patients with relapsed or refractory disease. For those patients who have undergone multiple lines of treatment with suboptimal efficacy or significant economic burdens, participating in clinical trials may be a worthwhile consideration.
That's a great question. And for me, the most impactful clinical trials are those that are zeroing in on mechanisms that seem to be recurring and important in treating T-cell lymphoma. Those mechanisms include drugs targeting PI3K, mechanisms targeting JAK1, mechanisms targeting the epigenetic biology, and of course pralotrexate, which globally affects DNA synthesis. And so what I believe is important of late has been 2 things. One is combination studies of those novel drugs. And in our hands, at least from my group, the combinations of histone deacetylase inhibitors and hypomethylating agents, romidepsin and azacitidine, have to date produced the most compelling, maybe the best, outcomes for patients with relapse disease of any drug combination that's been studied so far. And I think it's a testament to the benefit of these novel, scientifically driven combinations. And I think we got to do much, much more of that. The other compelling data that's coming from clinical trials pertains to the emergence of all these promising new drugs, like we talked about earlier with the PI3 linperlicib, the EZH2 inhibitor, SHR-2554, valmitastat, another EZH1/2 inhibitor. I think, and the recent approval of golidocitinib, the JAK1 inhibitor. I think those clinical trials, there's no doubt, are changing practice today. And I think we're only scratching the surface on the potential of those drugs to change practice because they're being used as single agents. We're not really optimizing their full capability by exploring and understanding the right combination. So I think that combinations, early combination studies of novel drugs are the most compelling, and the vast recurring array of smaller single agent studies like the PI3K, like EZH2, like JAK1, are all going to change practice, and they're going to continue to change practice as we move away from these paradigms of chemotherapy combinations and move towards more of a chemotherapy-free idea about treating these diseases.
The latest research on relapsed or refractory primary cutaneous T-cell lymphoma has primarily focused on the development of novel, small molecule targeted therapies and innovations in immune checkpoint inhibitors. In recent years, we have witnessed significant improvements in efficacy in the fields of PI3K inhibitors, EZH1/2 inhibitors, JAK1 inhibitors, immune checkpoint inhibitors, and histone deacetylase inhibitors. However, it is noteworthy that despite demonstrating certain therapeutic potential, the overall response rates of these small molecule targeted therapies as monotherapy are generally limited to between 30% and 60%, posing significant constraints on treatment options for patients. Consequently, the strategy of multi-drug combination therapy has become a key area of exploration, both currently and in the future. When formulating combination therapy regimens, it is essential to comprehensively consider the efficacy, side effects of the drugs, and whether there is a synergistic effect between them. Additionally, some emerging therapeutic regimens have demonstrated remarkable efficacy. For instance, the regimen combining brentuximab vedotin with bendamustine has achieved an objective response rate of up to 71% and a complete response rate close to 50%. This outcome not only provides us with a new treatment option, but also indicates that immune-targeted therapy may increasingly play a prominent role in the treatment of relapsed or refractory diseases, especially when the effectiveness of chemotherapy gradually diminishes in later stages of the disease. Meanwhile, oral-only regimens such as kitamide in combination with prednisone, cyclophosphamide, and thalidomide CPCT regimen have also shown good efficacy and exhibited excellent safety and tolerability profiles. These results further confirm the significant role of new drugs in the treatment of revolution per revolution PTCL and suggest that multi-drug combination therapy regimens will become a mainstream trend in the future. However, while pursuing efficacy, we must also pay close attention to the potential adverse reactions associated with combination therapy. Therefore, when devising treatment plans, it is crucial to fully consider individual patient differences, drug-drug interactions, and potential risks of adverse reactions to ensure the safety and effectiveness of treatment. In summary, with the continuous emergence of new drugs and the ongoing optimization of combination therapy regimens, the treatment prospects for PTCL patients are becoming broader. In the future, we will continue to explore more effective, safe, and well-tolerated treatment regimens, aiming to provide patients with better therapeutic outcomes and quality of life.